to cover tonight, or this morning, wherever you are in the world. So thanks so much for joining. My name's Melissa Withers. I'm the director of the APRU Global Health Program. If you don't know what APRU is the Association of Pacific Rim Universities, which is a nonprofit network of 60 leading research universities in the Asia Pacific. And we formed a network of people interested in global health. And one of our activities is working groups. So the working group on non-communicable diseases organized this webinar for you, featuring 4 experts in cancer prevention and control from Hong Kong, China, Vietnam, and Malaysia, who are going to speak to us tonight about their work. Before we start, I also would like to acknowledge the 2 co-chairs of the working group on NCDs, Dr. Martin Wong, who's with us and will be speaking, as well as Edmar Elacarte, who is in the Philippines at the University of the Philippines. So we're going to have our 4 speakers talk to you about their work, and then at the end, we'll have time for questions. So if you do have any questions, to be thinking about those, and you could put them in the chat for later. All right, so let's go ahead and get started. It's my pleasure to introduce our first speaker, Professor Noor Aisha Taib, who is a senior consultant breast surgeon and professor of the Department of Surgery at the University Malaya. She's currently head of the Cancer Research Institute, and her areas of interest are strongly correlated with patient care and outcomes. She's also a trainer for Master of Surgery in Malaysia and has a long and very distinguished resume. So please make sure to check out her resume on our website, and I'll put that in the chat in a moment. Okay, thank you so much for being with us, and please go ahead.
Hello, good morning, good afternoon, good night, and to everybody in the world. Thank you very much, Melissa, for the invitation to speak today. Can you see my slides? I'm going to just put it on the slideshow.
Yeah, so perfect.
Okay, so I think so let's just start. So I think this slide needs no introduction, I think, to most of the people working in cancer control. You can see now that breast cancer is actually one of the most common cancer all over the world. And you can see that the second, probably the common ones would be the prostate cancer, and then very small pockets of cervical cancer. So I think tackling cancer control is not new. So I think we have from the WHO a lot of reports and recommendations back even in 2017 on how to tackle NCDs. But how are governments really responding to it? And how are we really trying to improve the situation at home? So there's also a lot of initiatives, like, for example, the Global Breast Cancer Health Initiatives that look into 3 main pillars of how people should improve the outcomes in breast cancer mortality. And we know that this have been launched even back in 2021. And so let's go and zoom down to Malaysia, So this is our statistics on cause of death in Malaysia, published by the Department of Statistics. So you can see the 5 principal cause of death in 2019. Cancer doesn't really look very, very prominent here. Is number 5, right? So number 1 is ischemic heart disease, number 2 pneumonia, number 3 cerebrovascular. Even transport accidents are even much more common than the cancer deaths in Malaysia, so-called. So let's dive deep into the causes of death for males and females. Again, you don't see cancers anywhere prominently put into the top as a top reason for why the country should invest in cancer control, isn't it? So let's just go, I'll quickly zoom down to my talk today. Is cancer that important in my country? And what are the challenges with cancer control in my country? And what type of research that we're trying to do now? So the 5 principal causes of premature death, and also the same for death, in Malaysia is number 2 is cancer. So I actually look into the details of the data, and actually if you put everything together, if you notice from the other causes of death, they actually separated all the cancers into different types of cancer. So of course it will never be a very important disease to invest in Malaysia. So if you look at it, it's number 2 cause of premature mortality in Malaysia. And if you look at our top cancers, we have breast cancer, then we have colorectal, lung cancer, and then after that is lymphoma and so forth, right? So how about the outcomes in Malaysia? So there has been some reports in our country, the Malaysia Cancer Outcomes Report, or MyScan. Actually, if you look at our bellwether cancer, which is breast cancer, you can see that Malaysia doesn't do too well, really, compared to even our neighbors in Singapore. And also, if you look at how the survival rates in Japan, these are all 5-year relative survival rates. So in Japan, it's like almost 89%, and Malaysia, we're at about 66.8%. Okay, and the reason why we have this problem in Malaysia is really because of the late presentation of cancers. So this is the stage 3 and 4 cancers, and you look at our top cancers. So lung cancer, top the most, 75 to 88% are diagnosed at stage 3 and 4, and colorectal cancer is 63.8%. Breast cancer is 41%, and cervical cancer is about 38.5%. So if you look at the background, it's actually our National Cancer Registry report. So it's a little bit long, old data, but I think we also have a lot of challenges in our National Cancer Registry. So you can see that actually the stage has not improved. In fact, the latest report actually showed an increase in the trends of stage 3 and 4. So we are really dealing with symptomatic cancers that are, should be diagnosed at an earlier stage. And again, financial toxicity is the other problem that we see in our country, even though in the setting of universal health coverage. So we can see that about 7 in 10 people from private hospital and the government Ministry of Health hospital fall into financial catastrophe. And in Ministry of Health is 3 in 10. So it's actually quite a large problem that we have in Malaysia. And you can see that from our health expenditure, the out-of-pocket expenditure is tremendously high. So it's about 35%. And you can see that a lot of the expenditure is still in the Ministry of Health, but our GDP health spending is actually very, very low compared to the other countries in the region. So how about the cancer control program? Have we really looked into ways of trying to reduce it? So the National Strategic Plan for Cancer Control we've had, I think this is probably the third document that we put forward, and this is for 2021 to 2025, and we have very specific targets like reducing or downstaging breast, colorectal, cervical cancer by 25%, right? And improving the 5-year relative survival rates, and reducing, of course, the risk of premature mortality rates by cancer by a third. Also, it's also aligned to what the Sustainable Development Goals are. So how do we get there? So there are some data already published. So I'm just sharing the work that we've done in the past. So you can see that delays in presentation, diagnosis, and treatments are really an important issue in Malaysia. So about 35% delay presentation, 42% have a diagnosis delay. That means a resolution of diagnosis more than a month is about 42%, and treatment delays are about 36%. And these are all the median times to date of presentation delays, diagnosis delays, and treatment delays. Okay. And also this we published this to make it easier for non-technical experts, especially in our part of the world, because we don't really know how do we measure quality in cancer control? How do we improve delays, and how do we audit delays? So we actually have this published recently, and you can actually go into and have a look into this paper. So really, I think we are at the cusp, or the issue of how do we really improve to downstage and improve survival rates in Malaysia. We are looking more into implementation science. So implementation science is very new in Malaysia. A lot of our, grant evaluators, they're not very familiar with this. So it's not easily funded. Okay, so we go, why are you doing an audit? But it's actually implementation science, right? So a lot of publication has shown that structured implementation strategies designed to target systematically identified barriers can improve treatment uptake, and it is a powerful tool to aid in planning, implementation, evaluation, and iterative improvement of translating intervention and treatment guidelines into practice. So really, from the publication, we know these are the key principles: stakeholder engagement, application of theoretical frameworks, and rigorous ongoing evaluation. So this is what we hope to do. And I have to say, I'm a newbie at implementation science. I think a lot of our universities are starting to do this, and it is a very important research that we should be doing in our country right now for cancer control. So when we look into the issues that we have, we wanted to pick a pilot site to put forward a complex intervention in order to be able to see how we can really improve delays, how we can reduce barriers. So when we look into our data in the Malaysian data, we can see that over the years from 1970 to the present day, we are now more of an urban country, where 75% of the country is in the urban areas, compared to in 1970 when I was born, that was 28.4%. Okay, so most of the people are in the urban areas, and we also have evidence that even in urban areas, within the same hospital that has both public and private wing, there is a difference in the overall survival rates, and this is really specifically for breast cancer. And the reason is really advanced stage after doing multivariate analysis and all that. So actually, stage is still a major issue in why the survival rates are different compared between the public and the private hospitals. So we look and zoom down to the urban localities in Petaling Jaya, which is a city in Selangor State. And we were looking into which areas we should look at. And we picked Taman Medan, which is a smaller locality where we could really detail and zoom down into the population. So we have this area called the Legislative Assembly area, which is about 55 kilometers squared. And we have about 300 over residents in Petaling Jaya. But when we look and zoom down to Taman Medan, we have about the smallest residential, about 508 of them. So we know that in this place, there is one community clinic, which is under the Ministry of Health, which is called Taman Medan Community Clinic. And we have 2 cancer diagnostic centers, mainly in Hospital Shah Alam and My Hospital University Malaya Medical Center. So this is the project that I'm doing right now. It is called Rebong, and it's short form for Reducing Cancer Early Diagnosis Barriers in the Urban B40 group. So urban B40 means the below 40% of if you look at their household income strata. So, and this is in the state of Selangor, but of course we are picking a pilot site to do the implementation science. So the Rebong in Malay language, and I know Melissa can speak a bit of Malay from what I can see this morning, to mold the bamboo, which is one of the strongest element on earth, we must start first with the shoots. And Rebong is really the shoot. So that's what we were planning to do. So this is a really complex study where we have something like 7 sub-programs. And right now we have about 6 of them funded, and you can see that it's a mixture of different people looking from the gender studies, from Faculty of Arts, from lawyers and family medicine specialists, surgeons, nurses. So we have all kinds of people in this group, but essentially what we're doing is really also we have students, right, to do this. So it is really a study of the main 3 sub-programs, which is really looking into the health system and of course the provision of financing and all that. And then we're looking at the disempowering social, cultural, religious, legal aspect barriers in the community. And we are also looking into the communication barriers that we have in the community. So it's a 4-phase study, where first of all, we study using qualitative study, and then phase 2 is really we're developing training modules for community navigators, primary healthcare providers, which is doctors and nurses. And then we developed the community intervention and the strategic communication campaign based on our phase 1 results. And then the phase 3 is really implementing a strategic communication campaign. And phase 4 is to see how we can sustain this and develop a cancer control framework so that we can see how we could actually apply this to other localities. So Rebung is really trying to bring all the stakeholders together. So we have quite a lot of stakeholders. And I won't go into too much details, but essentially it cuts across government as well as the civil societies. And of course, within the government, we have different ministries. So right now we are at phase 4, which is the sustainability phase. So maybe I can just describe. So for the first sub-program 1, when in phase 1, we did the mapping and analysis of all our stakeholders. And we also mapped the health system, looking at how we use the diagnostic pathway for cancer care. That means we're looking into the top 4 cancers, which is breast, colorectal, lung, and cervical cancer. And then we did a lot of community engagements with the community. And then we developed the care pathways, looking into screening pathways for breast cancer, colorectal, and cervical cancer. And then we work with the different ministries that are actually providing the services. So Ministry of Health has community clinics, Ministry of Women have subsidized mammogram vouchers, and private hospitals actually provide the mammogram services, but paid by the other Ministry of Women's. So by providing this type of pathways, we are a bit clearer about how we can bring all the resources together to expedite this early diagnosis and screening for cancers. So there are many things that we've done. We've trained them using our information packs. And then we have this a sort of guide for the clinics to see how they're going to refer, and there are phone numbers that they can call to expedite the diagnosis to the Ministry of Health hospitals, which is really the safety net for our B40 group. Okay, so we have many of this type of information, and then Dr. Lai, my co-investigator who is looking into the social cultural barriers. So they found all these things, like people don't really do their annual checkups. They cannot differentiate, is it diagnostic or is it screening? There's a lot of stigma, a lot of financial issues, and then religion can be a source of strength, and then religion and community institutions provide the social and financial support. So there are a lot of programs that we did. So one was the Community Navigator program, which we use the ECHO platform to educate our community members and community leaders. And we use the YouTube as a way to sustainably forward information to the community. And we also use a lot of education on early diagnosis and screening pathways and how to navigate when they find a symptom or when they want to go for screening. So this is all for the top 4 cancers. So during the pandemic, everything was done using the Zoom platform. And these are a mixture of the community leaders. You can see they're mostly women. Okay, it was difficult to get men involved. And of course, the NGOs. Okay, I'm already at the 13-minute mark. So the primary care course was also done, and we used the open learning platform. So the doctors could actually do their own learning over a period of 6 weeks. And then we had the echo sessions with them to discuss cases. And we had nurses coming to our hospital to improve their clinical breast examination competency. And we work with Know Your Lemons Foundation to provide the education. Okay, and of course the communication campaign went on using also the YouTube video. So we are tracking the impact of the reach and all that. So the outcomes is really looking at reach, effectiveness, and we are actually using the data that the Ministry of Health hospital and clinics are collecting anyway to look at the impact of this project, where we want to look at the numbers of screen mammogram, numbers of clinical breast examination, all that. So what we have is we've provided a toolkit essentially on how we can actually do all this within one committee that we have studied. And we have moved on to physical campaigns. So we are now in the sustainability where we are actually getting NGOs, community leaders. So this is our parliamentarian who is doing a health campaign. So we work with them as well as all the clinic, all our NGOs Breast Cancer Welfare Association, Hospice Malaysia. So everybody is actually linked together. And how we want to sustain it is really to move towards community leaders actually taking the lead to actually continue the campaigns. So this framework of cancer early diagnosis really is by putting things together. And we have got a bit of impact. You can see here, we have engaged total about 150 people. We have about 93 research participants using qualitative methods. And these people are from different ministries, agencies, and also industry. And then we've done the training programs. We've done about 37 specialists that were involved in the development of those training kits. Okay, and we've trained not that many, but again, this is a small pilot site. And we have now got 12 community navigator volunteers who is actually doing a lot of work in the community. And of course, the personnel doing the early diagnosis navigation within the clinics. We have about 8 doctors, 3 nurses, and 3 administrative staff. So I'm just gonna, I think that's my last slide. Sorry. Okay. Yeah. So this is our way forward. Yeah. Thank you, Melissa. Thank you for listening. Okay.
Thank you so much. And hopefully we'll have some questions for you at the end. I appreciate that a lot. Okay. Very interesting project. Thank you.
All right.
Okay, let's move to our second speaker. So I'm pleased to introduce Dr. Wenheng Xu, who is a professor of epidemiology at the School of Public Health at Fudan University. She graduated from the Shanghai Medical University, the bachelor degree in preventive medicine, and also has master's in epidemiology and biostatistics and PhD in epidemiology. She has more than 20 years experience in epidemiologic research on cancer and other NCDs. Thank you so much for being here with us. Nice to see you again.
Thank you, Melissa. Thank you for your introduction. I'm Wenheng Xu from Fudan University School of Public Health. It's my great pleasure to be here to share with you our recent research results on lung cancer overdiagnosis in Chinese women. I will report our results according to the outline of background, hypothesis, methods, results, and conclusions. As we know, lung cancer is the second most common cancer and the leading cause of cancer-related deaths around the world. In China, the 5-year survival was only 10 to 20% during 2010 to 2014. So due to the heavy burden of the lung cancer, LDCT was introduced to China to be used as the annual employee health examination since 2012. The wide use of LDCT in China was based on the evidence of 20 mortality reduction in high-risk populations, and its non-invasive nature and high sensitivity, and the low price and easy to access of the examination. Overdiagnosis refers to detection non-progressive cancers or cancers that don't cause clinical symptoms or death. It was reported that about 0 to 67% lung cancer cases were diagnosed in screening trials. The evidence also can be obtained at the population level. The combination of a dramatic increase in incidence and stable mortality is of pathognomonic of overdiagnosis of population level. Recently, a study in Taiwan proposed that the raising early stage incidence not followed by a concomitant decline in late stage incidence was also for pathognomonic of overdiagnosis in a setting with a stable risk. That this figure shows the first, this one, the incidence increased dramatically, but with a stable death. That's the figure shows the how overdiagnosis presented in population level. So obviously, the LDCT was used in low risk populations, not high risk populations, including non-smoking women. That's raise a concern on the overdiagnosis of lung cancer. So we hypothesize that the overdiagnosis of the disease may exist in Chinese population, and tested the hypothesis at the population level based on the cancer surveillance data of the Pudong area of Shanghai. Why Pudong? Because it is the biggest district of Shanghai, and the LDCT may be more popular in more commonly used in this area. We obtained incidence and death data of lung cancer from cancer surveillance of Pudong area, and obtain population data from the Statistical Bureau and the Public Security Bureau of Pudong area of Shanghai. All cases were classified as 5, 3 or 4 year periods and 15 age groups, and historical subtypes of lung cancer were recorded in cancer registry as squamous cell carcinoma, adenocarcinoma, small cell carcinoma, and other non-small cell carcinoma in cancer registry according to ICDO. We defined the stage 1 as the early stage and the late stage as stage 2 through 4, stage 4. We calculated age standardized rates, use the world standard population. So we calculated age standardized incidence and mortality by 6 age group, stage, and calendar year. And the joint point regression model was applied to evaluate the trace of incidence and mortality. All cases were followed up to December 2019 for vital status to calculate a 5-year survival rates for those newly diagnosed during 2022 to 2014. Estimates of overdiagnosis use the incidence rate ratio relative to the base year of 2002, and use the excess early stage incidence and accounts. We also run sensitivity analysis by redefining early stage as stage 1 and 2. As shown in this table, a total of more than 34 incidents and more than 27 deaths of lung cancer were recorded in cancer surveillance system of Pudong area of Shanghai. This figure shows the evidence 1 for the potential of overdiagnosis of lung cancer. We can see that in men, the incidence of lung cancer decreased between 2002 and 2008, and the mortality decreased from 2002 to 2009. And since then, both incidence and mortality changed slightly. We can see this take a look at the 90% interval of APC. But in women, the incidence of lung cancer increased dramatically since 2011, but the mortality consistently decreased over the whole period of observation. Since the LDCT was used popular in China since 2011, so this figure, these results provide evidence because it shows the dramatic increase in incidence and relatively stable mortality in women, as provide evidence for the overdiagnosis in Chinese women. For the analysis show that the increase in incidence was main observed for non-adenocarcinoma, with a sharp increase since in incidence since 2011. This table shows the age-specific incidence risk ratio of squamous cell lung cancer and adenocarcinoma lung cancer relative to the base year 2002. We can see this line is for female, this is for the male. We can see that the incidence of adenocarcinoma increased very rapidly since 2012 in young women and men. But the squamous cell lung cancer, mainly squamous cell cancer, remain stable over the whole period. For the analysis shows that the incidence risk ratio was stable in men, but increased significantly in women. And the increase was mainly observed in younger women and stage 1 cancer and for the mainly adenocarcinoma. All these results provide evidence for the overdiagnosis of lung cancer, mainly non-adenocarcinoma in young Chinese women. Let's take a look at the evidence tool. That means the increase of early stage cancer without the decrease of later stage, as shown in this table. This is the mortality. This is the early stage cancer. This is incidence of early stage cancer. We can see that in men, the incidence of in men, the increase of early stage increased, but this is the later stage. The red line is the later stage cancer. We did not find any significant change on the mortality. And in women, the increase in incidence is more evident. And similarly, we also see the stable later stage of lung cancer, as mortality of later stage cancer. And this figures shows the incidence, the rate ratio of 5-year survival. That's for the 5-year survival, and the incidence of early stage cancer. As the red line is the later stage cancer. We can see that the rate ratio of 5-year survival almost parallel to the early stage incidence. As that means the benefits in 5-year survival was mainly from the incidence, the increase in incidence. Maybe partly of them were overdiagnosis. So we further estimated the number of overdiagnosis of lung cancer in men and women. We can see here this because the LDCT was commonly used in China since 2011. We can see that the number increased rapidly since this year, in both men and women. Although this estimate may be overestimated, this number may be overestimated because the existence of undiagnosis of lung cancer in 2022. But this number may help to quantify the overdiagnosis of lung cancer in China. So in conclusion, our results provide evidence at the population level for lung cancer overdiagnosis in Chinese women, possibly due to increasing LGCT use in these low-risk populations. As we know, the smoking rate was only 2 to 3% in Chinese women. So we suggest that the criteria for LGCT screen and the management of screen detected nodules should be fully addressed for expanded application of GCT screening in China. That's all. Thank you for your attention.
Thank you so much, Professor Xu, for that really very interesting talk. And I am sure we'll have some questions at the end. So thank you once again. Let me see. Let me introduce our third speaker for this evening. We're very fortunate to have Dr. Tung Pham with us, who is a lecturer and researcher at Hanoi Medical University and a third-year PhD student in cancer epidemiology and prevention at the Harvard T.H. Chan School of Public Health. During his MPH training at Johns Hopkins, he focused on global cancer epidemiology and prevention. And after returning to Vietnam, he's worked as a research associate at the Center for Population Health Science at Hanoi University of Public Health, and also as a faculty member at Hanoi Medical University. So please join me in welcoming Dr. Pham. Thank you.
Hi, everyone. Today I will present to you information on cancer in Vietnam, the burden control effort, and the need for more research in Vietnam. So this joint presentation that I prepared with Professor Hoàng Văn Minh, who is the Dean of the Hanoi University of Public Health. So I want to talk a little bit about Vietnam. If you don't know where Vietnam is, so Vietnam is located in Southeast Asia. We have a population of nearly 100 million people in a very small piece of land. Our GDP per capita last year is around $3,000, and the current life expectancy is around 75.4 years. Our population mostly live in rural area with around 61%, and the current health insurance coverage is around 75%. As our aging problem continue, you can see that in the early 1990s, the percentage of individual age over 60 in Vietnam is only around 7.2%. But it is expected to rise to around more than 20% in 2039. So therefore, we will have a lot of issues with chronic disease and especially cancer. To talk briefly about how the healthcare system is organized in Vietnam, the public system is vertically organized, with primary healthcare center consist of commune health center and district hospital. Located close to small population center. We also have provinces hospital. We provide mostly advanced service for people within that province. And at the national level, we have hospital run by the Ministry of Health who provide special service that are not available in other area. We also have other ministry health facility mostly to serve their employer and employee within the region. And we also have a thriving private sector healthcare with nearly 200 hospitals and more than 35,000 clinics are currently working. Regarding the cancer burden in Vietnam, according to Global Can 2020, across on site, we have around 180,000 cases. And the age standardized rate that according to the world population is 159.7, and the number of deaths is around 122,000 cases. All of these statistics seem to be triple in the last 30 years. Regarding the top cancer in male and female, you can see that in male, the top 3 cancer are liver, lung, and stomach cancer. With liver and lung have very similar age standardized rate. Compared to women, the 3 top cancer is breast, lung, and colorectal. And breast seem to be the most dominant cancer in women, with the age standardized rate nearly triple compared to lung and colorectal cancer. And according to a study in 2009, the state of diagnosis of cancer in Vietnam seem to be very poor. You can see that like with breast cancer, it's about 50% of the patients show up at late stage, colorectal around 70%, especially with like lung, stomach, and liver cancer, more than 80%. And the overall like diagnosis at late stage in Vietnam around 7 to 80% if we like try to survey the whole country. So the patient arrive very late and their quality of life very low at this stage. The 1 year incidence of mortality is estimated to be up to 25%, and the 1 year incidence of financial catastrophe is around 68%, which is the highest in the Asian region. And the percentage of household with cancer care that become impoverished, that means like fell below the country poverty line after paying for all direct medical costs, is very high, around 37.4%. And when compared to other disease, a study in 2008, the Vietnam Burden of Disease and Injury Study estimated that cancer was estimated for 22% of all of the total life loss in Vietnam, around 1.5 million year, rank only lower than cardiovascular disease, and account for 14% of the total adjusted life year loss, that is around 1.7 million year. Talking about like the current cancer control in Vietnam regarding primary prevention, we have some infection control in place that is why to the national expand program on immunization. The HPV vaccine have been included in 2005. The HPV was not included, and most people have to pay out of pocket to get this vaccine. There have been some talk about including this, but currently it was not rolling out yet. As regarding other risk factor, there was some program aimed at like controlling some behavioral risk factor. For example, like mainly it was like the tobacco control program. It was some policy that would put in place, and the smoking prevalence reduced around like 10% from 2002 and to 2015 in men. Currently, there are no other national program for unhealthy diet, alcohol use, and physical activity. Here is like the graph that we have on like the risk factor for all non-curable disease that also contribute for cancer from 2010 to 2015 that are surveyed by the national survey. So the smoking in men seem to be like decrease gradually, like a few percentage over year, while harmful drinking, overweight, and overweight seem to be increasing, and physical activities seem to be stable. Why there currently like no national program on this? Like we are advocating for the government to pour more money in controlling these risk factors. Also regarding primary prevention, like currently like there no organized program to increase awareness regarding cancer. In a 2010 study on 20,000 people in 20 different provinces, only around 30% of the people have correct knowledge of cancer, and nearly 50% of them thought that surgery would make cancer patient die sooner. So the study also point out that like the more socially disadvantaged people are, the lower knowledge of cancer that they have. So that is also something we should work on. Regarding secondary prevention, currently in Vietnam, there is no national screening program for any type of cancer. We have some pilot programs that are sponsored by some NGO and like international partner, but like it was only limited to a few facilities and also only cover colorectal, cervical, and breast cancer screening, and can only cover around 2% of the target population. Some reasons that are preventing the scale up of this program is a shortage of trained personnel at the primary healthcare center, lack of like equipment at the center, and the lack of appropriate funding mechanism from the social health insurance. Because currently our insurance system covers 75% of the population, but they didn't pay for like the screening service. There have been some advocate on changing the social health insurance law to cover this service, because like it could be better for the future and saving money overall for the health insurance system. Regarding tertiary prevention, regarding our diagnosis and treatment capacity, like mostly our cancer treatment are provided at the national or provincial hospital, located mostly in the big city like Hanoi and Ho Chi Minh City, which means the people live in the rural area have to travel very far to get like diagnosis and treatment. And they would like a study in 2010 shows that like 10 out of the 63 provincial hospitals were unable to provide adequate cancer-related service for patients. So that means like people in these provinces have to go even further to get the cancer treated and diagnosed. Surgical and medical oncology like radiotherapy mostly be available in urban area, and some very modern technique like immunohistochemistry, molecular analysis, and radiotherapy and other advanced services mostly available at national level, like big hospital that run by the Ministry of Health at Hanoi or Ho Chi Minh City. And palliative care are very limited, only available in like big city, and there currently no like organized hospital care for cancer patients in Vietnam. So we also like take a look at like what is the state of cancer research, because these are the evidence that could generate generated toward like so the policymaker would know what to address in the future and what the gap need to be addressed in order to understand cancer in Vietnam, so we can have a better prevention policy. So this is a graph that we compiled from PubMed that's showing the number of like publication in the field of cancer in PubMed in Vietnam from 1952 to 2021. You can see that the numbers seem to be increasing like rapidly. But like when looking directly at the study, we found that like the overall data on cancer burden and control is still deficient. And most of these studies, even though they are increasing in number, most of them have a small sample size and would localize to only one facility. They would know properly design population cohort with cancer outcome yet in Vietnam. There was some small clinical studies that include patient follow-up, but that are not like have enough sample size to do like more complicated like analysis. Most of the article also would design cross-sectional of case control rather than a population-based cohort. Another case study is that like the statistic mostly we rely on is the global CAN 2020. But like when looking directly at the data source and method of global CAN, when they calculate for Vietnam, that like the incident data, they use like the cancer registry in Hanoi and Ho Chi Minh City, and use a weighted and simple average of most recent local rate to apply to the 2020 population. And when like looking directly at the weight, they weighted like the rural area is 64% and urban area is 36%, but they don't have any rural rate for Vietnam. They had to use the national mortality data from like many years ago and converted to incident using the mortality to incident ratio from the Chinese cancer registry, which means that it is very like prone to bias. And the urban rate in Vietnam would obtain from Ho Chi Minh City and Hanoi City cancer registry, but the data would very outdated, and they use that rate to apply to the 2020 population. And then like regarding mortality, it was mostly estimated by using a Southeast Asian model from global CAN. So the problem, even with these cancer statistics, that is like the basic for policymaker to make any policy change, is that the mortality data is incomplete and could be heavy biased, and the incident rate of like Hanoi and Ho Chi Minh City to like only cover 10% of the population, and then the rate for rural area would mostly like using data from other country registry. We also prone to bias, and own estimate would based on a very outdated and not accessible data. So one of our recommend we are trying to advocate for is to strengthen the cancer registry for better incident estimate in Vietnam, because if we don't know what the incident is, it's very hard to argue for like whether or not we should invest more into cancer control. Currently, only 9 out of the 63 provinces in Vietnam have their own hospital or provincial registry. And the current registry also does not account or provide any data on survivorship, mortality, or quality of life. So the World Health Organization and other like international partners also recommend that Vietnam should develop additional cancer incident registry and bolster the quality of the current site. And we also like advocate for more study to improve like the mortality estimate, which is a big weakness of like cancer burden data in Vietnam. We should have a national death index system with a cost of death that is available online, so that could be linked with like other population-based cohort study and have funding to design a properly like population-based cohort with cancer and other NCD outcome in the future. So thank you. That's like the end of my presentation.
Thank you so much. Excellent recommendations, and I look forward to speaking to you more about that in just a moment. So we have our fourth speaker for this evening, Dr. Martin Wong from Hong Kong, who's a specialist in family medicine and a researcher on cancer screening and prevention of chronic diseases. I'm super jealous because he has over 300 publications and received many awards. He's also been selected for Master Teacher and Annual Teacher of the Year award for 7 years. He was conferred as an honorary fellow by the Hong Kong Academy of Nursing to recognize his achievement, and many other things that you can find on his bio and the other speakers' bio. So Dr. Wong, thank you so much for being with us.
Thank you very much, Melissa, for your very kind introduction. I would like to firstly share my screen. It's my honor to join this very prestigious symposium. And the topic today is to share some of the recent research on colorectal cancer screening. So I'm from the Chinese University of Hong Kong. And I declare in the first place that I am an honorary medical advisor without remuneration of a company called Genibiome. And this Genibiome company produces Microbiota. Because I will talk about the microbiota produced by this company, so I declare potential conflict of interest. But I did not receive any remuneration from sales of any biomarker products. So to start off with, so I think everybody knows that, and also our speakers have actually mentioned that colorectal cancer is one of the leading causes of cancer deaths globally. And then in Hong Kong, it's now the #1 cancer, being the most common, and the second leading cause of cancer deaths. But there's one good news is that, in fact, colon cancer is highly preventable, treatable, and also beatable, but only given early identifications, screening, and also accurate detection of polyps and also the cancer itself. So globally, it's also a big problem here. Okay, sorry. For this one, I removed that in the first place. Yeah, sorry about this. Okay. So this slide is really just talking about the global burden of colorectal cancer. We've got 1.8 million new cases having colorectal cancer in the year 2018. It ranks the second in women and also the third in men. So as you can see here, colorectal cancer occupies quite a large proportion of morbidity and mortality. And it accounts for 9.2% of total cancer mortality in the world. And it also represents recently a 2 to 3-fold rise in Asia Pacific countries. So as you can see here, this is actually a map showing the distribution of colorectal cancer. Of no surprise, it is now rising very rapidly in Asia Pacific regions, including a number of countries which are relatively well developed. So therefore, we need to really think about combating it, targeting towards the risk factors associated with colorectal cancer. So I think these are very familiar to you already, like clinical factors like previous colon polyps, history of inflammatory bowel disease, some of the hereditary syndromes, the presence of diabetes, and also use of certain drugs for osteoporosis, and also for inflammatory bowel disease, what we call ursodeoxycholic acid. There's one which is an emerging research target, and it's now a very, very hot topic, being microbiota. And this microbiota could affect our risk of having colorectal cancer. As you can see here, these are the relatively non-modifiable risk factors of colorectal cancer. Yet there are some modifiable factors which could be identified, like reduction of obesity, healthy diet, physical activity, as well as cessation of smoking and alcohol drinking. So what's the rationale? Okay, I'm probably actually place my slides here if it's fine. The major rationale of colorectal cancer screening is because of its relatively long history of development from just hyperproliferation, or what we call polyp, down to adenomatous polyps to cancer. And in fact, this very early stage takes around 10 years. And lastly, when cancer occurs, is talking about 10 to 15 years. So I think primary care professionals, public health experts, including you here, will be in a very privileged position to screen for these key cancer lesions, where we can actually remove them timely. Because if cancer was discovered or detected at a relatively early stage, the 5-year survival is up to 94% versus relatively low 5-year survival of 11% for stage 4 cancer. So we understand screening can reduce cancer mortality. This is before screening, and this is after screening. So similarly, for males and females, we can see a very rapid reduction of colorectal cancer risk because of that. And so there are some of the screening tests which have been shown to be quite applicable, but I think the most common one will be fecal immunochemical tests and also colonoscopy, among the other modalities. And in fact, in a number of Asia-Pacific countries, they have now shifted the use of qualitative tests to quantitative one, which allows a certain cut-off level of hemoglobin concentration to act as a point for positivity or negativity. So you might probably ask, so all the problems are solved. We don't need to do anything, because if the countries adopted fecal immunochemical tests, this would perhaps be something like, colorectal cancer has already been eradicated. What unmet needs? Indeed, we got a very substantial unmet need, but because as we can see here, FITs and also stool DNA, they have a relatively low sensitivity to detect non-advanced adenoma, advanced adenoma. They're good for colorectal cancer, but they're relatively not so good to detect non-advanced adenoma and advanced adenoma. So therefore, it comes to a concept of microbiota, which consists of 10 to 100 trillion symbiotic microbial cells, and it's even 10 times more in terms of number of cells than our human body. So if it has microbiota being out of balance, that will be called gut dysbiosis, which could contribute to a very broad spectrum of diseases and also colorectal cancer as well. So it's very important, therefore, to have more study on this gut microbiota, because it could potentially lead to colorectal cancer. And this is also one of the major causes of colorectal carcinogenesis. And as we go on, we can actually have a glimpse of a pilot study by our team back to the year 2017, published in the journal Guts. We can see here, using Fusobacterium nucleatum for advanced adenoma and colorectal cancer, the abundance is relatively higher in colorectal cancer patients. And this is another which shows the performance of Fusobacterium nucleatum markers, we can see if we use the Fusobacterium nucleatum marker, the area under the curve is actually outlined by the blue one, where the area under the curve is 0.95, much higher than FIT in terms of sensitivity and also specificity. Now, this is actually another paper which shows the use of microbiota to detect adenoma, not colorectal cancer. And it's found that for colorectal cancer and adenoma, if you use a combination of these bacteria, including Leishmaniosclerotidium, M3, a combination of Fusobacterium, Clostridium heavyweighti, and Bacteroides claris. So these LR4, a panel of biomarkers, can achieve a sensitivity and specificity of 77.5% and 75.3% for colorectal cancer. And for adenoma, it's also much superior to FITs in terms of detecting adenoma. So it's very high figures. That means it has a potential to detect adenoma, not just colorectal cancer. Now, these are the existing non-invasive tests. What we are going to highlight here will be this one, with a sensitivity of 94% for colorectal cancer and up to 44% if the adenomas or polyps are large enough. So the diagnostic performance of the biomarker panel, that means the Leishmaniosclerotidium M3 species, together with other 4 bacterial species, increase in the symbiomes and also the pathobiomes. And then the area under the curve is very high when we are trying to use this biomarker panel, with non-advanced and advanced adenoma having a sensitivity of more than 40%, which is much more impressive as compared to FIT. Now, this is to directly compare M3 plus bacterial biomarkers with the FIT. So the blue bar shows a much higher sensitivity for non-advanced adenoma detection, more than 40%, advanced adenoma detection, and colorectal cancer detection. Very high levels of sensitivity compared to FIT. So this is also true for different stages of colorectal cancer, not just adenoma. But then FIT fails to detect that. And we have to say that, in fact, in Hong Kong, there are quite a number of people who refuse to receive FIT, simply because of the fact that FIT fails to detect adenoma. So if we use this bacterial biomarker panel, we might probably also remove the psychological and intellectual barrier of people not going for screening. So therefore, this panel can quantitate colorectal cancer and adenoma-specific markers. They can be used as an at-home kit, shipped to the laboratory, and results will be available within 15 working days. I also need to declare that in Hong Kong, now it's already in use, approved for use in a private market, and it's around 3,500 Hong Kong dollars, which is we're talking about, say, less than 500 US dollars. So it's actually quite, patient friendly. For those richer people, they might probably really think about this. So, in summary, this biomarker panel detects 94% of cancers comparable to colonoscopy and also precancerous polyps. It also, however, serves another purpose of indicating individual gut microbial health. Now, this one is actually a hypothetical sort of test result. So an individual tested for this biomarker panel may have the marks here, which indicates his or her colorectal cancer or colorectal adenoma risk. And we have the risk for colorectal adenoma and cancer as well. And the second panel is also very attractive because this could actually give tailor-made dietary recommendation for that particular individual who has been tested for these M3 tests. For instance, that particular patient got a slightly lower risk of colorectal adenoma and also lower risk of colorectal cancer, intermediate risk. So this will be up to the patient to discuss with the doctor on whether the doctor will recommend colonoscopy or simply because the risk is quite low, the individual can choose to be screened 3 years later. Okay, 1 to 3 years later. So also, this is actually the dietary recommendation, tailor-made to each individual, taking more cooked whole grains, beans, nuts, and seeds, etc. All right. So high score indicates double spouses, whereas low score indicates a good balance. My last slide is really just to say that now there's a recommendation for these tests to be administered to almost everybody if they are concerned about their colorectal health. And also, if they would like to screen for polyps and colorectal cancer, they can start to screen at the age of 45, which is according to the American Cancer Society. And regular screening of 1 to 3 years is recommended to achieve the best results. So our studies got these patents. So this is a declaration, and our team will work together very closely, including more randomized control trials being needed, because still our sample size is very much limited. So we wish to expand a little bit more in the future. So we've got papers from these tests, and then I probably end my presentation here. I apologize for a little bit of technical problems of my PowerPoint, but wish if we have time, we might probably collaborate. And we, Melissa, we really look forward to collaborate and talk to our fellow colleagues here. And thanks once again, Melissa, for your very kind invitation. I totally enjoyed the talk. Thank you very much.
Thank you. Thanks so much, Professor Wong, and all of our speakers. I'm still trying to digest. I'm not a cancer expert, so I understood about half of that, but I'm digesting, I'm learning, so thank you. And we do have a number of questions. So I would also like to acknowledge, I forgot to mention, since it's brand new, we're announcing that another co-chair of the APRU Global Health Working Group on NCDs, who's with us today, Jason Huang, is it will be a co-chair, or I'm announcing it right now. So thank you for volunteering for that important role. And our first question actually is for Dr. Xu, which asks, what are your suggestions for reducing overdiagnosis of lung cancer?
Thank you for your question. Right now, in my opinion, maybe the government should issue some policy to restrict the use of too widely used of the RTCT in medicine or in screening. In opportunistic of screening, that's the point. That's the very important point. The second is the medical education to told people just when and how to use the RTCT, because it's very cheap in China, and is easy to access. So almost every company or institutes to provide it as a screening item in the package. As for me, I already take 2 times of RTCT, but I am not so old, and I'm not smoking. So, but it is our university provided this benefits for me, so I take it. So I should medical education is very important. That's the second point. So and the third is to redefine the lung cancer, the definition of lung cancer. I was told many stories. Some young lady was diagnosed with non-adenocarcinoma, maybe very early stage. It was not fatal, but once he was diagnosed with it, his marriage, his everything is ruined. So I think the lung cancer should be redefined. What is the lung cancer? It should be the adenoma should be excluded, or as the just as the precancerous layer just. So I think this should be defined. Okay, that's so. Thank you.
Thank you so much. Our next question is for Dr. Taib. Is the overdiagnosis of breast cancer a problem? And it seems there are some recent studies from the US that show that 14 or 15% of breast cancers were overdiagnosed. Is that common also in Malaysia?
Yeah, thank you for that question. I think in Malaysia, we do not have a population-based screening program. And most of these screening mammograms are done opportunistically. And as you saw, most of our patients are still presenting with very advanced disease. So the issue of overdiagnosis, I think you may belong to two different camps, because the overdiagnosis evidence is there. But I think at this moment, you can't really tell when you make the diagnosis whether this is going to be something of a benign cause or not. So most patients who are detected through the screening mammogram will be treated similarly. So I don't think out of a clinical trial, we can safely tell the patients, that we won't be able to treat you or carry on with the treatments or diagnostic procedures when we detect something on the mammogram. So the short answer is there's no overdiagnosis in Malaysia at the moment. We may have among the people who undergo opportunistic screening, but we still we don't have the data to substantiate that at the moment.
Thank you so much. Okay, let's see. The next question is for Dr. Pham, who says, the question is, why is liver cancer the #1 cancer in Vietnam? Is liver fluke still a problem there, or what are the major risk factors? How do you explain this?
Yeah, so liver fluke is also a problem. And like the thing is that like the hepatitis B vaccine have already been included in the immunization program in 2005. That means like only people who are very young receive the benefit of this vaccine, and this tend to happen like a 20 to 30 year lag before we see a decline in liver cancer. Most people in Vietnam who have liver cancer right now, they don't receive that vaccine when they are born. So since when they was born, so that is one of the major risk factors. Another thing is that like in Vietnam, like the consumption of alcohol seems to be on the rise. So that might be another reason that contribute to the rise of liver cancer.
Thank you. And a related question is there an association between socioeconomic status and incidence of liver cancer?
There could be, but like because in Vietnam there are no currently like population-based cohorts, so we cannot make that causal relationship yet. But like the patient who have like what socially like economic like in Vietnam seem to have like at least like with where if they have cancer they would be detected later. They would be their barrier to access to like diagnosis and treatment would be higher compared to like the people who living in urban area and have health insurance and have like disposable income.
Thank you. Okay, thanks so much, Dr. Wong.
Yes.
Is the Hong Kong research also investigating the link between folic acid intake and colon cancer risk?
Thanks a lot, Wendy, for the question, and thanks, Melissa. In fact, for this question, we have a glimpse at the past literature. There has been a meta-analysis published in the year 2018. I think it's by the journal called Chemical Nutrition, and they included quite a lot of studies from the year 2000 to September 2016. So they said that in fact, folic acid supplement intake show no significant effect on colorectal cancer risks in a meta-analysis of randomized controlled trials. But the interesting thing is the effect on risks was, however, significant between folic acid intake and colorectal cancer in cohort studies and cross-sectional case control studies. So now the controversy is really still here, and then we have to actually examine what additional experiments should we perform in order for this research question to be more conclusive. I myself think that is actually quite harsh because there are already many trials there. So shall we do a meta-analysis of another meta-analysis? That will be another question to see whether it is effective or not. In fact, I think the answer lies on whether a patient has a balanced diet. If the diet is already very balanced with adequate folic acid intake, perhaps folic acid supplementation may not be very helpful. But I thank you very much for this very good question, because thus far, I think only aspirin has been shown to be a chemoprophylactic agent for colorectal cancer, which is effective. Others like calcium, fish oils, and folic acid may not have been recognized as a chemo-preventive agent. So thank you very much.
Thank you. And another question for you, Dr. Wong. Are the novel tests cost effective when we're talking about large population-based screening for CRC?
Thank you very much. If we're using the individual costs of the test, is quite so-called quite expensive relative to FIT. So we have $500 plus doctor consultation fee. Therefore, it is not cost effective. But however, if we are doing population-based screening, that means the government will purchase a whole bulk of the M3 biopanel for testing. That the unit cost of that particular test will substantially reduce. And in that case, that will be cost effective as compared to colonoscopy or FIT. So this depends on the scenario of opportunistic screening. Definitely not cost effective. But mass population-based screening, say Hong Kong, we've got 7 million individuals. If the government is willing to purchase these kits from a company, the company will actually offer a very low price. So in that case, it will be cost effective. Thank you very much for this question.
Thank you. A question for Dr. Pham. You showed exercise levels remaining stable. Did you see any relationship between exercise and certain cancers like lung or breast cancers?
Yeah. So like currently in Vietnam, as I said before, there is no population-based cancer screening, but like physical activity have been shown to have like some effect on certain kind of cancer like colorectal cancer. Yeah, but currently like we don't have any evidence yet that look into like whether or not it have like an association with like cancer incidence or cancer death in Vietnamese population. Yeah.
Thank you. And Dr. Tybee, you mentioned health systems barriers despite universal screening. Could you talk more about those?
Yeah, I think the case for Malaysia is that we're a bit schizophrenic, because we want to have screening, and then there's a lot of, in Malaysia we have both private and public health systems. So the private sector can provide even enhanced care. So there is this breast health global initiative, stratified resource care. That means you can have enhanced care. That means you can even have genetic testing and all that. But you also have basic care. So in Malaysia, it's like you have this more basic care in the public service and very enhanced care in the private sector. So we're almost schizophrenic because everybody wants to be screened, but there's no population-based screening. And what Prof. Martin Wong mentioned, that when you have opportunistic screening, it may not be cost-effective because we haven't actually strengthened the diagnostic care yet. So for example, the delays that I've mentioned just now, the students showed that there's about 40% delays in diagnosis. That means it takes more than a month to make a diagnosis of breast cancer, which is really not really acceptable. But in the setting where we have not sort out the barriers within the health systems, because to actually diagnose a breast cancer, you need a multidisciplinary team of specialists. And in some of the public sector hospitals and even the private sector hospitals, they have single specialists, people working within the hospital. So definitely there are a lot of health system barriers, and we're just talking about diagnostic centers there, but what about between primary care referring to the diagnostic or the secondary and tertiary care hospitals? So there will be barriers. So financial barriers is also one of the issues. The patients are not able to even afford transport between the primary care to the diagnostic centers. So health system barriers is something that is a bit understudied, I think, in our part of the world. And right now, I think more resources should be put into, because people, audits are not sexy, a lot of academics are not interested in doing research on, let's say, quality improvement projects or, but these are the research methods that we need to use in order to improve the state of affairs in our countries. Because I think for us, as you can see, stage 3 and 4 is still very high. And our mortality rates is still not as high as we could be. So there will be a lot of ways to improve, to sort of remove the barriers. But how do we do that? How do academics put in some more, added value to the country to ensure that we will improve our care as well as our outcomes for our cancer patients? So I truly feel that the implementation science research methods should be really, really, really quickly brought into our part of the world to quickly just improve whatever we have. We have so much resources. It's just that we have not put it in an organized fashion. And how do we do that? We need implementation science research. So I hope that we will find more people doing this type of research and more grants will actually pay for this type of research. Yeah.
Thank you. Dr. Xu, is the risk factors for lung cancer among women the result of air pollution, behavioral factors, smoking? Can you clarify those points?
Actually, the risk factor for lung cancer of women is still not well understood. Yeah, for men, maybe smoking is the most important risk factor for lung cancer. But for women, because most of Chinese women did not smoke, so the risk factor is not clear. Maybe the reproductive menstrual and reproductive factor maybe play a role in the development of lung cancer, because the family plan, the strategy always changed. For the older generation, they have many children, but since 1978, the issue of the only one child policy lasted maybe 30 years, and until now the family plan is changed. So the young couples are encouraged to give birth to have children. So that's I think the strategy, the shift of the strategy may contribute to the incidence, the increased incidence of lung cancer in Chinese women. Yeah, that's the case. I hope I have an opportunity to design a good study, epidemiology study to test the hypothesis.
Absolutely. Wow,
Yeah.
that would be a definite unintended consequence of that policy, right? So I think we're out of time now, but I would like to once again thank all four of our expert speakers for really their fantastic talk. I certainly learned a whole lot, and I would also like to thank all of our participants. Thank you so much for joining today. And I would encourage you to keep a lookout for other APRU Global Health Program events coming up, including our next webinar, which is on humanitarian disasters and conflict. And I just wanted to show you this screen. So, assisting vulnerable populations in conflict situations. Speaking about Ukraine, Afghanistan, Timor-Leste, and other places with 4 experts from our network. It's taking place on September 20th or 21st, depending on where you are in the world. And you can find more information on our website. So thank you again for joining, everyone, and have a wonderful day or wonderful evening.